Yeah.
Okay.
So we kind of divide the labrum on the socket kind of into, I mean, realistically into 4 parts, but 2 big parts based on function. If we call, so obviously on the left shoulder, if we call this as being the front, if this is say 9 o'clock and this is 3 o'clock, and we draw a line from 3 to 9, call it at the equator, the labrum below that line is the attachment site for the ligaments that provide stability for the shoulder.
That's like in the front here?
That's kind of in the armpit.
Oh, armpit down here.
Yeah. So when people dislocate their shoulder with normal anatomy without hypermobility, by definition, when they dislocate, they have to rip the labrum off the socket with the ligaments.
Oh.
When you have hypermobility, you can pop the shoulder out, subluxate, or even get to a point of dislocation without having such damage to the shoulder because of the stretchiness in those ligaments that are attached to the labrum, if that makes sense. However, over time, over repetitive instability events, we may start to see scuffing, evidence of fraying. Sometimes you can start to eventually tear the labrum because it's happened so many times.
And the labrum is the little part that kind of holds it all in.
Yeah, exactly. It surrounds the socket. And so that's the lower half of the labrum. The top half of the labrum above the equator functions differently because it's actually the attachment site for the long head of your biceps, one of the biceps tendons. And so that's looking at it kind of face on. You can't really assess it very well in this view though. So when I look at, let me go back to here, because my head was totally, this is all instability, I'm going to see something related to instability. If we look down towards the armpit and kind of work our way up towards the top of your shoulder, this is the front of the labrum, this is the back of the labrum, so obviously socket. Generally, when you've torn, you start to see cracks to the labral tissue. In your case, that's not really happening. No tearing in the labrum. Sometimes, especially when there's multi-directional instability, like it's so stretchy that it can, subluxate posteriorly, inferiorly, anteriorly. You can start to see fraying. I do think there's some fraying of the posterior labrum, actually. The back, you can see it's a little bit less organized, less of a triangular structure, a little bit more modeled, so to speak. So I think there's some fraying of the posterior labrum at the bottom, and then as we make our way up, that the posterior labrum towards the top actually kind of peters out. You don't really see much structure there anymore. And
that's supposed to be? And
that's when you get into biceps territory. So I think, interestingly, in your case, most of your pathology is actually related to the biceps tendon more than anything else. And another way to assess that, if you look at the biceps tendon, this is it right there, this little black dot. You can see it sits in the sheath. The sheath has some fluid in it, that white signal around it. And as we come up, it takes this turn. But as it takes this turn, in your case, it loses the intensity of the signal. And that's usually an indication that something frayed. If you look at it from the front, and I often use the analogy that the biceps tendon is kind of like a rope on a sharp corner in this region of the shoulder. If you go up and down with that rope on a sharp corner, over time it starts to fray. That rope will start to fray and eventually thin out. And that's, I think, exactly what's occurring to your biceps tendon. As it takes this sharp turn, you can see it's no longer dark and black up here, it gets gray, and there's just not much organization to the fiber. And then when you look at the labral attachment site at the top, it's just very attenuated or very weak, a weak signal, and the labrum itself looks detached. There's this little kind of like crack through it. So there's also, looking at the rotator cuff, you have rotator cuff anatomy that I consider pretty normal in someone with hypermobility. When you have hypermobility, the way that you offset the ligamentous hypermobility is that you start to really load your rotator cuff tendons more and more frequently. And so you're providing stability for your shoulder by just constantly engaging the cuff tendons. And so there's evidence that they are tendinotic, a little degenerative, but there's no discrete tearing in the top half. There's a little layer of fluid above. This little line of white above the rotator cuff is the subacromial bursa, subdeltoid bursa. And so there's a layer of fluid showing that it's irritated, but no discrete tears in the cuff. With the exception of the subscapularis, which is in the front. And I think there's a little partial thickness tear. If you follow this subscapularis, it's attached to the bone, and as we come down, there's this little blip of white. It's kind of like a partial tear of the subscapularis. And interestingly, that's often associated, this region of the subscapularis, where when it starts to tear like this, it's often associated with bicep symptoms as well, because we think that subscapularis attachment is actually kind of a bumper for the biceps, and so when the subscap starts to tear, the biceps can start to pop in and out of that groove a little bit because it no longer has
which
that
could
bumper.
cause more wear and tear on that.
Yeah, exactly. In your case, I think the biceps looks like it's in its anatomic position, but it is subluxed, meaning it's like about to pop out of that groove, and then it's only hanging on by the fact that there's still subscapularis attached. Not like it's not completely torn off, and that biceps is really frayed. So I think, interestingly, I don't know. Treatment for this could be all over the place. If we leave this alone and don't do anything, I suspect that this biceps will continue to fray and get worse, and it may actually rupture on its own over the course of time. And no way to know how often that happens. Obviously, if you are doing a lot of lifting, it can happen much faster than if you kind of lay off and understand that this is sort of a tenuous issue right now. But I wouldn't sit on this for years. Basically, I think if you wait too long, it may just rupture, and then there's not much you can do once it's actually ruptured. So then the question is, well, what do we do about it? And I think options, surgical options. We have surgical options, I think, and you may be at that point. Most of it can be done arthroscopically. I think meaning like through small puncture wounds around the shoulder to get our cameras in to do it all minimally invasive. What I think may be part of the problem here is that if the biceps itself looks really frayed at this level, sometimes trying to anchor, so basically, let me back up. The treatment for this is often when the biceps itself looks really ratty like this, and the labral attachment site is also kind of peeling off the socket. Generally, we can't just repair the labrum back to the socket up there. It just doesn't have as good of a blood supply, and so it doesn't heal very well or predictably. And so a better treatment for that is usually to release the biceps, actually cut it off of the labrum, debride that part of the labrum, just smooth off any sort of remnants that might be unstable, and then actually tenodesis or relocate that biceps downstream and pin it somewhere else. So it keeps its tension, keeps its function. It just removes that segment of biceps that's causing the pain.
Would you still have pain from that long term, or would it?
The goal is if you do that, it removes it completely.
And would it tighten things up so that they don't?
No, that's the thing. So we have to think about this in twofold. Number one, if we're in there already, and even though we don't see a lot of displaced labral tearing where we can usually find it with instability, but we're doing things to the labrum upstream, up at the top half, even though it might be just a debridement. The idea is we probably tenodesis the biceps. The question is, would we be able to do arthroscopically, kind of at the top here around the groove, or would we have to make another incision closer to the armpit and actually tenodesis it below the pec tendon, which tends to be more reproducible. Like that healing is very reproducible and usually goes well. It's just a little additional incision to do that. But then the question is, if we're already there, should we deal with the instability? And probably. And we would kind of hang our hats on something called an examination under anesthesia. When you're sedated, we really get a sense of how unstable your shoulder is, try to dislocate it. And if we can actually dislocate it, it's safe to do it when you're sedated, obviously, but
Because you're not going to be aware.
correct, and you don't have like a fight in it to stop it from happening, so we can actually get a good sense. But if we can destabilize you and to dislocate your shoulder anteriorly, inferiorly, and even out the back partially, then I think we would probably, if we're in the room, might as well tighten things up, and that would be kind of like a labor repair with something called a capsular shift, by taking the slack out of those ligaments and pinning them back to the labrum and kind of tightening it up a little bit that way. And so, if it's just the biceps, the recovery is kind of the same in the sense that we usually put you in a sling for 6 weeks to get this biceps to heal. If we're doing that anyways, and you're unstable, might as well fix that because it's the same type of rehab. The difference is you just typically with the shoulder stabilization, you have to fight through quite a bit of stiffness because we've tightened things up, and so there's usually this 6 to 12 week period after the sling comes off. Sorry, a 6 week period after the sling comes off, so between 6 and 12 weeks.
So 6 weeks for recovery and 6 weeks for rehabilitation to get things back moving again?
Yeah, but the recovery is actually much longer.
Oh, yeah.
So that's just getting through the aches and pains of the surgery.
Uh-huh.
The idea is if we do just the biceps, you shouldn't have as much stiffness. Usually you come out of the sling and you're stretching and it's your range of motion is pretty quick to be restored, but then if we tighten things up, then you're breaking through a lot of stiffness and some of the scar tissue that builds up from the healing. And so usually it's a little bit longer, I think, if we do all of it, but just on the front end. I think you can't do any strengthening until 3 months anyways, regardless if it's a tenodesis or a stabilization or both. And so I think once you get to the 3 month mark, you probably catch up with, if we just done the biceps only. So, full recovery is probably like, I mean, you're probably doing a lot by 6 months. You're probably back to most things, but there may still
So
be
I
some
get a lot of pain back here too. Do you think that's related to this?
You've had some neck things too.
Yeah.
Yeah, that's the.
I also have my hip.
Yeah, that's the wild card, is the neck may be a play here. And so, and have you had any updated imaging actually? I don't know.
I did have an MRI several years ago of my neck, and I did have a X-ray on
Oh, yeah,
ability.
Yeah, this is from March of last year.
Yeah.
Yeah. Oh yeah, yeah. What is 1, 2, 3, 4, 5, 5, 6? Yeah. I mean, that's like classic. Do you have symptoms going down the arm at all?
Yeah, and my elbow has been causing a lot of pain, and I don't know if it's related to
Where?
this elbow right here.
Like where on the elbow? On the outside? Or the
It's
inside?
actually all of it, but it's more inside
Oh.
and all the way up to here.
Is it related to certain things? Like
It's
repetitive things?
constant,
Oh,
but
it is?
sleep and
Oh, does anything make it worse? Like picking things up, moving your wrist in a certain way?
everything hurts down to here, from about here to here.
There. So this may be. Oh, who's seeing you for your neck?
No one.
No one. Um.
I had seen someone previously years ago when I was with Legacy, and they told me, oh, well, we could do a surgery to help, but we highly recommend that you don't do it because things will hopefully improve over time. And oftentimes when you fuse necks, you'll end up with other discs going out. And I have one disc that does herniate in, I don't know here, I don't remember the name of it. And then also my lower back, my L5 is fused from birth.
Oh, okay. Yeah.
I don't know if that has anything to do with anything, but
Well,
it was only
sometimes.
discovered by accident when I was seeing a chiropractor in Australia, and they're like, oh, we usually do x-rays before we start, and
Smart.
yeah.
Yeah, I think this may be a little. I think there may be a little bit of play here for the neck. It could be some kind of pinched nerve. The question is where, like, what maybe we should do is, do you have pain, like, so there's neck pain,
Causes chronic headaches all the time.
no numbness or tingling though? Down to the-
Definitely some in my left hand.
Okay, so you do. Okay. I think it may be worth, you said you have not had an MRI recently though?
No, it was
But you did have an
probably
MRI somewhere.
around 8 to 10 years ago with Legacy, and I think they transferred over the records.
Nothing here. So I think for the shoulder, I probably have you, let me just see here, probably set you up to meet with one of our surgeons to talk about just kind of potentially moving forward with this. Obviously with that, with the understanding that, just from, because you also work, you have a farm, right, or something? Yeah, so you're not, I know you have help, so it's not like you're
Well, mostly it's on me. I'm
okay.
a single mom with
So,
4 kids, so.
Well, all right. So then that's something to consider, because obviously with recovery, you'd have to have a lot of help.
Help,
Yeah. Being in a sling for 6 weeks, we wouldn't want you lifting more than like 2 or 3 pounds for those first 6
On
weeks.
this side, is this side okay to lift
That's-
still?
Not more than like, not more than like 15 to 20 maybe.
Okay.
So
At least my kids are a little older, like my
Okay.
youngest is almost 7, so.
yeah. I think I might do this. I think we can slow roll this. I don't think, like I said, I don't think we should sleep on the shoulder for too long, like meaning years,
Uh-huh.
two or more
Sorry, I
years.
was literally thinking I can't sleep on this side.
Oh, yeah, no, that's fine. You just don't want to do any sort of like biceps loading. Like you don't want to pick up anything heavy on that side that may start to cause it to fray more rapidly and maybe auto-tenotize it.
How
Well-
likely is it that it would rupture if I picked something up? Like, that might encourage me to not do it.
Yeah, I mean, probably not, it's probably not that likely unless you do something like, say an air conditioning unit's falling out of the window, you go to stop it from falling with that sudden forceful
But I
loading.
like dig trenches and holes and stuff to redirect water in my farm
Yeah.
because things
I
like that
mean-
probably shouldn't do.
Probably not as much. Yeah, I mean, you can do it, just really listen to your shoulder. If it seems to if it's getting irritated, then you probably just want to back off to as much as you can.
Do you think that physical therapy was a bad idea? Because he had me doing a lot of like things like this with
No, usually
because it
unless,
definitely hurt.
yeah, unless he was doing biceps heavy loading, which usually they wouldn't be doing like usually it's either curls or the biceps is really responsible for this movement. So often if you're digging trenches, right, or you're digging post holes, like your hands that's a lot of biceps. And so Shoveling is another thing, but if you keep your hand, like I think if you keep your, I'm trying to think which way you should do it. I think if your right hand is lower on the shovel, you could do that more safely than if it's the left hand lower down, because that is really loading the biceps more, if that makes sense. So yeah, it kind of depends. The position of your arm, and obviously like the force and repetition. I think repetition.
Well, it definitely wasn't helping, and I
Yeah.
quit doing it mostly because I didn't have childcare, but also because I don't think it was improving anything.
Yeah.
And probably wasn't gonna, because it was probably something
Yeah, I think
different
the-
than what you thought it was. So.
Yeah, I think that's probably what it was. I think the bicep, I think it's just really irritated in the biceps. Plus the subscap is kind of is injured too. So I think when those two things are compromised, it can be very painful and everything just hurts, obviously. And then if you're not sure what's going on, then it's
When he was trying to strengthen this area, thinking that it would help support this area.
Yeah. Which is rational, and usually that's what PT does. But when you have pathology, it doesn't always get you as far as you want.
Mhm.
So yeah, I think if it wasn't quite as frayed, if the labrum itself looked a little bit better, if there wasn't as much fluid inside that bicep sheath, I think, and if the subscap wasn't partially tearing, I think we might be able to kind of see how far PT would go. Sometimes we can push it along with injections, like steroid injections to optimize it, reduce the pain. Would not inject this though, because obviously steroids will just potentially make it weaker, like the tendons, that kind of stuff. And it's just a band-aid, it's not fixing anything anyway. So yeah, two things. I think we should get you in to meet with one of our surgeons. They're really booked out right now, so I think we have at least like through the end of the summer to kind of just take the can on the road, see how far this gets you. I do think you should, we could update your PT if you want to go back and just like modify it in a way to like reflect obviously what we know now. Or if you feel, what I would say is what you could do just, and obviously work a lot too, so I don't want you to you need rest. Obviously that's important, recovery in between working and all that. But realistically, when you do any sort of labor, you want to put most of your focus in your back, like in the scapula. And so if you're shoveling, you want to really pull with your shoulder blades. You don't want to you don't want to use your arms as much, that kind of thing. So a lot of things you can modify. I think we should get you in to see maybe the spine clinic just to get their opinion. I mean, they may want an updated MRI, so maybe we can. I just don't know.
I tried with I had a naturopathic doctor, and she was trying to get an MRI of my back because she thought maybe I had trying to remember the name of it. Low down, where the spine kind of gets stuck. I'm trying to remember the name of it.
Sacrum?
No, where the spinal cord kind of gets stuck to the wall. There's a name for it.
Oh, not
Like a tie or something.
like a tether?
Yeah, tethered cord.
Oh, weird.
She thought maybe that was potentially an issue. Because I haven't been able to sleep with a pillow in my neck for a long time, and she thought maybe my spinal cord couldn't straighten all the way because it was tethered lower down, maybe.
Interesting.
Anyway, my insurance wouldn't cover an MRI there, so.
They often get kind of squeamish about authorizing neck and just spinal cord stuff, just because it's there's oftentimes you're not recommended for surgery, and so I think they just try to save money where they can. We could try to get an MRI of your neck, see if they authorize it. If they don't authorize it, then I think we wait.
In the
still try
past,
to-
they did allow a neck one, just not a lower back.
Interesting. Well, we can try. If you want, I can order a neck MRI. But I do think we should get you in to see spine, maybe the spine clinic, just to get their evaluation. They probably won't recommend surgery, obviously, either necessarily, unless there's something really egregious on the MRI, which I wouldn't expect that to be the case.
Is there anyone I can see for my left hip as well?
Remind me what's going on with the hip?
Well, it does pop out of place sometimes, and it definitely causes pain.
You haven't had any imaging though? Yeah. One of my colleagues here, Carmen, she works with one of the surgeons here that does hip arthroscopies, it's like hip preservation stuff. Might be worthwhile maybe seeing her for that. So get some x-rays, get a look at, we can make some measurements to determine if there's, dysplasia too, like a shallow socket, or if it's just part of the hypermobility
I'm
spectrum.
hoping it's just that.
Yeah.
I'm gonna deal with that anyway.
Yeah,
So.
and so that is always labor, we sometimes do labor repairs on hips, arthroscopically, and it can get those rehabs are also very challenging, because you walk in your hips, unlike the shoulder.
Right, I'd rather have arm stuff because
Yeah.
I don't have to use
Yeah.
it.
Yeah, hip arthroscopies are just notorious, those
My
rehabs are
main thing is I
notorious.
want to prevent things from getting worse,
Yeah.
not go through surgeries, but is there anything I
Yeah.
can do to stop it from getting worse?
Yeah, so I think start with X-rays just to see what the measurements look like. Usually, it's you got to do like check some boxes off before they authorize. Usually have to get an MRI arthrogram, like with contrast injected into the hip, really to get a good look at the cartilage and the labrum. Just that it helps delineate a little bit more effectively. And then depending what that looks like, I will tell you with EDS, I think the labrum often becomes really frayed. It's kind of like what we're looking at here, in the sense that you don't get like this discrete labral tear. Like people, like runners for instance, who tear their labrums in their hips, usually it's like this crack and it's separated, and then you look at it, it's obvious on the MRI, you can stitch it back together. Hypermobile folks with labral pathology, it's usually frayed labral tissue where it's becoming really just kind of like mushy almost, because it's just constantly trying to hold on to the hip. And so sometimes it's the surgery for that is a little bit less predictable, because again, you're tightening things up, trying to tighten things up, but you're not trying to over tighten the hip, because that makes things worse. Like,
I was thinking about
it can go in a lot of
yesterday, I
different
think,
ways.
connective tissue disorders and sorry, I have it all in my mind. Like stem cell transplants. Can they do stem cell transplants to make your body produce collagen better, or?
Yeah, not that I know of. That'd be a good. Someone should start researching that though.
It's like maybe you can reverse this in
But
people. That'd be nice.
Yeah, it is a genetic thing. So there's got to, like, you think if they can train
Yeah,
cancer
someone
cells to stop being cancerous, like you think you can train collagen cells, or like tenocytes, and tendons, and the cells in the collagen to like produce better quality collagen.
Yeah.
But nothing yet. Sometimes you can try to do like platelet-rich plasma, like PRP, which is not stem cell, but it's a biologic injection. Your blood drawn, reduced to plasma and platelets. The idea is it mimics an injury, and then it creates this inflammatory process, which can help to encourage your body to heal things. There's no data to say it helps in hypermobile folks, but in theory, you think if it mimics an injury, it might help to cause some stiffness in some of the ligaments, but I don't know. Again, it's an out-of-pocket cost, no insurance to cover it, so.
Yeah.
And naturopaths kind of notoriously have your old charging arm and a leg to do it, so. We do it for $500, but per shot, just because it's kind of recouping the cost of the kit. But it's hard to get in and have someone to do it. Yeah, I think there are options, but I do think, like I said, the way the biceps looks, I think it's worth at least having a discussion about surgery. We may need to do something about it, and then if we're in there, we might be able to just tighten everything up too,
Prevent it from happening again.
Yeah.
And so if you do the surgery, what is it likely to be fully recovered to where I can use it like a normal person again, or is it still going to be like a little compromised, or?
That's a great question, and we don't know always. With people with EDS, sometimes it heals initially really well, and then it starts to stretch out again over time. Sometimes it just never heals really well, and some people
But having it anchored down here might be better than having it anchored here where it's going to keep wearing, maybe? It goes over the bone, doesn't it?
You talk about the labrum? Or the ligaments? The ligaments create this, this like hammock here. It's kind of like this like U structure. You can see how they attach from the humeral head to the bottom half.
So there's not really anything to wear on.
No.
I imagine it kind of went over and kind of attached in there.
Oh no, yeah, that's the biceps does that. So the biceps will continue to fray potentially, eventually.
I imagined it like this is a rope, and you've worn it down to just a little bit left,
Oh.
and then how easy it is to just snap that little bit, and maybe that's not how it is.
Yeah, it's more like if you look at this, like like collagen, especially in the biceps tendon, when you look at it arthroscopic, like surgically, it's this kind of shiny. It looks like a rope, but you can actually see the fibers moving longitudinally, right, along the length of the almost like fiber optic cable, so to speak. But it's kind of it should be a smooth, glistening rope. When it starts to fray like this, when we look at it, you start to see splits. Like the collagen you'll see like separations between the collagen. Sometimes like on the surface there'll be like areas that are kind of like flipped over and frayed. So sort of like almost like a rope, like a cable.
It's starting to
Yeah.
cut down.
Yeah. So and so it's just when you start to see that pathology, especially in this region, like I said, then it gets weaker, and like obviously it can get more and more frayed, but it is really difficult to assess that level on the MRI because it's taking this like sharp angle and doing this like oblique turn, and it's hard to really get.
So it may not be that bad.
It may not be that bad, but it also may be worse. But usually if you can see this signal and the labrum looks pretty compromised, like the labral attachment site at the top looks compromised, can venture. It's almost a sure bet to know that to like assume that it's frayed at least to some degree. So and it's not going to get better. Yeah.
I've been looking at Popeye syndrome, and is that likely?
Yeah. Yeah. So that's what happens if it ultimately ruptures. A reverse Popeye occurs when the distal biceps ruptures, and then it kind of comes up. The normal Popeye is when it ruptures from the top, but because you have two tendons attached, only one of the tendons is the one that ruptures. And so if it ruptures and it slides down here, you might notice a bump on the outside of the arm, but not the whole thing, if that makes sense. Usually like this part's still good, but this part's where there's a bump.
Mm-hmm.
And usually there's like sometimes you'll feel it, sometimes people just like will see bruising out of nowhere.
Mm-hmm.
It's not always.
I bruise out of nowhere anyway.
Well, I was gonna say, you
I got this really bad bruise right here. Like I have no idea where that came from.
Who knows? Yeah. Yeah, I think let's get you to see one of our surgeons end of the summer. Just kind of stay active, keep up your strength. Try to avoid doing too much biceps loading when you can, especially repetitive or heavy.
My concern with summer is I've got kids I need to drive to school after summer.
After summer, yeah, I see. So are you? I'm trying to think here. Trying to think of like the timing for this. I mean, I could try to get you to see someone maybe a little bit sooner, but it's between like planning and all that, it still would be like surgery would still wouldn't happen for probably
School time.
yeah, honestly, like even if we got you in like next month to see somebody, yeah, just the way or just we have really bad access with our OR.
Mm-hmm.
Alternatively, we could like have you meet them and then maybe come up with a plan over the winter, maybe, you know, might be reasonable too, because then obviously like you probably aren't doing quite as much on your land.
Actually, it's
Is it worse?
maybe worse because I have to carry animal food bags and feed the animals that don't have access to grass and that naturally is there.
Yeah, there's always something, huh?
Yes.
I'm
And
not
there's more
sure.
mud and more water and more.
Oh man, I'm not sure
There's
how to
less
do this.
weeds though.
I guess that's fair. I'm not sure how to plan this. Well, I think it may be, how bad is like the tingling?
It's pretty constant. I don't
Is
know
it?
what you mean by how bad is it. Like
Well, I mean like, so it's pretty
I can do
constant.
things with it, but it's constant.
You notice any grip, like are you
It
grip
feels
weakness?
weaker, but I don't know if it is because I don't know how hard I'm squeezing.
Because of the numbness?
Yeah, it feels numb to like right in here. Actually, I can feel it in my fingers too.
Yeah, I think we should get you to the spine clinic. Yeah, I think have them look at it, because they may, depending on how that all plays out, it may be worth addressing that first anyway. I will say, even if this biceps ruptures, like most people, other than the Popeye sign, like if you have that, that's usually just like a cosmetic deformity, and like I said, it may not even be that bad.
Can it be reattached if it's been a while?
No, I mean you could theoretically. I mean you could do it if you find a surgeon willing to do that, but you end up having to make this really big incision to go hunting for the stump of the tendon, which is really traumatic in and of itself. And then you go digging around, you find it, and then you try to pull it back up. You have to release it from all the scar tissue around it, and pull it back up and
My
retension.
concern is if it gets to that point, I'm gonna lose that, and then that's even less support to keep my bones in place.
Well, I was gonna say, it's often serendipitous almost, meaning like it ruptures and often the pain just eventually goes away once it kind of finds its home and scars in wherever it ends up scarring in, because it's gone, it like does it itself, like it removes it as a source of pain. But the problem is, yeah, I think, yeah, I mean you'll lose some strength with supination, but generally it's not like that noticeable unless you're doing a lot of like wrenching or like the supination type like movement. So I think people that we get concerned about where if it ruptures it may compromise their function are like people who do a lot of wrenching or like shipbuilding, that kind of stuff. Generally with like digging, farm work, like you probably would notice a whole lot of weakness or pain. But like I said, I think, I don't know, I mean we prefer not to have that happen if we can. Yeah. Like I said, I think this is not like exactly like a ticking time bomb, but it's also definitely looks ratty, and I think, you know, we don't want to delay this too long. But then again, so for you, timing would be best in the summer almost.
Yeah, almost, because I got kids in school and.
Well, one of the surgeons here has better access, but he does not usually, if the biceps looks bad, he usually just releases it actually. Like he doesn't actually reattach it, he just kind of cuts it and then just slides down somewhere.
So they might as well rupture. It's no
Yeah,
different, right?
that's kind of, yeah. Sometimes he'll repair it, but only if it looks like everything kind of seems healthy, then he'll repair the labrum actually. But like I said, there's just not a lot of good data that says that that's reproducible. So he's a little more old school, I guess, is what I'm trying to get at. But he's a little bit faster to get into. The other surgeon, one of the other surgeons, Andrea Hertzke, could probably get in to see her maybe in like the next 6 weeks or so. But surgery planning still would be, like I said, tail end, like probably not till the school year start, just based on like our limited access. The other surgeon is booked, like you'd be seeing her maybe in September initially, and then we could plan something. I mean, it may almost make sense to like table this until next summer if this is the case. Not that, like I said, not that it's makes us feel good to wait that long, but
We'll see what we can do, and maybe different support will be there. My oldest daughter, she has a baby, but my second oldest daughter lives at home, and she's 18, and she's finishing school right now. Like she had a few extra credits to finish, and she should be finished by the summer, but she's not driving still, so I need to get her getting her license.
Yeah.
She'll help me out a bit more, I think.
I think we should, so depending on the spine thing too, I think we need to really make sure all of our ducks are in a row. I don't want to ignore the spine or like the neck thing, because I think that's playing a role.
And it's been an issue for a long time.
Yeah.
Actually, I remember when I was a toddler, I remember having issues in my upper back and neck, and
Yeah.
my lower back has been a big issue too, but
Let me